Over the last couple of years, immunotherapy has become integrated as a core component in our treatment of advanced non-small cell lung cancer. This started with second-line treatment a couple of years ago and now is increasingly used in the first-line setting. But we haven't defined a place for immunotherapy in earlier stage non-small cell lung cancer where we might actually improve the cure rate. The next foray is in the setting of locally advanced disease, which is a full third of our patients with non-small cell lung cancer. These patients with stage 3 or locally advanced disease are typically treated with a combination of chemo and radiation over 6 or 7 weeks, and we do not have any therapy of proven benefit after that. The cure rate with chemo and radiation is only in the range of 20%, maybe at best 25%, and we have tried to demonstrate that adding more chemotherapy or targeted therapy after that could improve outcomes. We've also tried increasing the radiation dose. All of these have shown either no benefit or actually a harmful effect, and so we are left at an impasse trying to improve on the rather mediocre results with chemo and radiation given over 6 or 7 weeks. The Pacific trial was just reported as a press release as being positive. The Pacific trial gave everybody chemo and radiation and then randomized patients who had not demonstrated progression of their disease at that point to either a year of placebo therapy or a year of IV durvalumab, a PD-L1 checkpoint inhibitor, every 2 weeks for a year. And the primary endpoint of the study was progression-free survival, and we learned from that press release that it met that endpoint. So does this mean that this is definitely the new standard of care for everyone? Not necessarily. It's definitely encouraging to know that there is an improvement in progression-free survival that is statistically significant, but we haven't yet seen the data. We expect that those data will be presented at a major meeting in September or October of this year. But until then, we just need to see what we can find out. If the statistically significant difference is just 3 months in progression-free survival, that's not necessarily going to be enough to justify having everyone do an additional year of IV therapy instead of just being done with treatment at 6 or 7 years and potentially being cured. We will really need to see a dramatic improvement in progression-free survival, I think at least 4 months, ideally 6 months or longer, or we will need to see an improvement in survival. We will need to see that we are curing more patients by giving immunotherapy to everybody. In addition to the challenge of just having patients go on a year of additional treatment, this is going to cost an additional $180,000 or $200,000 or so per year. And that's probably a reasonable justified cost if there's a big prize, if we are curing patients. But if we're only postponing the time before patients develop a relapse of their disease, it's not clearly that beneficial to treat everybody for an additional year just to postpone progression that would ultimately occur anyway. However, we really just need to see the data. We will see the actual trial reports in the next few months, and we may well see a change in the standard of care that is very welcome and needed to break through the impasse we've had for so long in stage 3 lung cancer.